I'm Lisa Sun, and I'm presenting a research project done as a regional anesthesia fellow at Stanford Hospital. This study was a randomized trial looking at the erector spinae plane block for total shoulder arthroplasty as a phrenic-sparing alternative to the interscalene block. I have no disclosures. We currently do not have a block that provides adequate shoulder analgesia and is completely diaphragm-sparing. The interscalene block is the most common block performed for shoulder analgesia, and it can cause up to 100% incidence of phrenic nerve palsy and a 9 to 12% incidence of dyspnea. The high thoracic ESP block is a recently described block which has been reported in case reports as providing effective analgesia for the shoulder region with no phrenic nerve block. This study compares the high thoracic ESP block catheter to the interscalene catheter in patients undergoing total shoulder arthroplasty. The primary outcomes of this study included incidence of hemidiaphragm paresis in PACU and median pain scores through postoperative day 2. This study was performed with IRB approval and was also registered on ct.gov. The first primary outcome was hemidiaphragm paresis, which was determined using ultrasound measurements of the percentage increase in diaphragm thickness at end inspiration compared to full expiration. This measurement was done pre-block and in PACU. Hemidiaphragmatic paralysis was categorized as none, partial, or complete. None was defined as 0 to 25% change from pre-block to PACU measurement. Partial was defined as 25 to 75% decrease, and complete was defined as more than 75% decrease. The other primary outcome measured was median pain scores from PACU through postoperative day 2. Our secondary outcomes included change in incentive spirometry volumes, motor and sensory function, opioid consumption, and activity and mobility score, which is routinely assessed by physical therapy on postoperative day 1, adverse events, time to PACU discharge, and patient satisfaction with the block. Preoperatively, baseline pre-block measurements were done by research assistants. The patients were randomized in a 1-to-1 ratio, and both patients and research assistants collecting the data were blinded to the type of block. The regional anesthesia team then placed the assigned catheter and bolused the catheter with 10 mL of 0.5% ropivacaine. On arrival to PACU, the catheters were bolused with 5 mL of 0.5% ropivacaine to reset the block, and then 30 minutes later, the PACU measurements were performed. Postoperatively, all patients were followed as per routine by the acute pain service. They were all run on intermittent automatic boluses of 0.2% ropivacaine. The interscalene catheters received this at a rate of 6 ml boluses every hour, and the ESP catheters received this at a rate of 12 ml boluses every 2 hours, given that this was a fascial plane block. This is the flow chart for our study participants. 30 patients were consented, and subsequently 2 had to be excluded, one because of delayed patient disclosure of chronic opioid use, and the other because of possible underlying cardiopulmonary disease. The remaining 28 patients were then randomized with 14 to each group. In the ESP group, 2 patients were not included in the final analysis because one patient was unblinded prior to block placement, and for the second patient, the ESP catheter was unable to be threaded in the ESP plane to a satisfactory extent, so they were removed from the study. There were no significant differences in baseline characteristics between the 2 groups. In terms of hemidiaphragm paresis, the high thoracic ESP group had no hemidiaphragmatic paresis compared to 100% incidence in the interscalene group of either partial or full hemidiaphragmatic paresis based on our ultrasound measurements. There was also a greater decrease in incentive spirometry volumes for patients in the interscalene group. For example, in PACU compared to pre-block, the interscalene group volumes decreased by 44% compared to 9% in the high thoracic ESP group. In terms of median pain scores, in PACU, the interscalene group had significantly lower pain scores compared to the high thoracic ESP group, with an average median score of 1.3 for the interscalene group versus 3.8 for the high thoracic ESP group. But subsequently for post-op day 0 through post-op day 2, there was no significant difference between the 2 groups for their median pain scores. In terms of cumulative opioid consumption, there was no significant difference in cumulative 48-hour opioid consumption for the 2 groups. But the cumulative opioid consumption for post-op day 0 was significantly higher for the high thoracic ESP group compared to the interscalene group. There was a 57% incidence of partial or full motor function loss in the interscalene group compared to 0% in the high thoracic ESP group. And in terms of adverse events, in the interscalene group, there were significantly more adverse events, with an overall 29% of patients experiencing some adverse events compared to 0% of patients in the ESP group. So in the interscalene group, 1 patient had dyspnea, one had hoarseness, one had Horner syndrome, and one reported subjective difficulty with PT due to motor and/or sensory block. And finally, there was no difference in time to PACU discharge, their mobility scores on post-op day 1, or patient satisfaction with the nerve block between the two groups. Limitations of this study include the following. It was only powered to detect a 50% difference in hemidiaphragm paresis and was not powered for other outcomes that were measured. There was no placebo control group because our standard practice at our institution is to provide an interscaling catheter for these surgeries. And it would be interesting to consider other measures of postoperative functional outcomes rather than just focusing on pain scores and opioid consumption. In terms of the high thoracic ESP block, this technique is newly described and it can be challenging, as we found with one patient in that group in whom we were unable to thread the catheter to the appropriate level. So this demonstrates that anatomical fascial plane anomalies can affect the success of this block. So in conclusion, the high thoracic ESP catheter was shown to provide satisfactory postoperative analgesia after total shoulder arthroplasty. However, the ESP group did have a 2.5-point higher median pain score in PACU. It was 1.3 versus 3.8, although subsequently there was no difference on postoperative days 0 through 2 for their pain scores. The high thoracic ESP group also had higher opioid consumption on postoperative day 0, but there was no difference in their 48-hour cumulative opioid consumption. The benefits of the high thoracic ESP catheter over an interscaling catheter included no hemidiaphragmatic paresis or paralysis and less adverse events. This study demonstrates that the high thoracic ESP catheter can be a viable alternative to the interscaling brachial plexus catheter that is completely diaphragm sparing. Thank you for your time.